Next, I call upon Dr. Sindhu S. To talk on the topic anti-VEGF injections, what's been there and what's new.
A very good morning to all of you. So, first of all, let me say there is no financial interest in this presentation. So, coming to the history, in 2004, the first anti-VEGF, that is pegaptanib, was approved by FDA for using for neovascular age-related macular degeneration. Bevacizumab came in the same year, but it is an off-label use. It was initially invented for the purpose of treatment of colorectal cancer. In 2006, ranibizumab, that is the Lucentis, was approved for neovascular AMD. 2011 came the aflibercept or Eylea, which was approved for neovascular AMD. 2019 was the brolucizumab for neovascular AMD. 2022 came the faricimab for neovascular AMD and DME. And 2023 we got the 8 mg aflibercept, that is Eylea HD for neovascular AMD and DME. So as Dr. Anu said, the first with FDA first drug was pegaptanib or Macugen. It is an RNA aptamer oligonucleotide, but it blocks only a single VEGF isoform, that is 165. It was available as a pre-filled syringe of 0.3 milligram. And the VEGF inhibition study in ocular neovascularization trial showed that it was effective in all types of neovascular AMD, and the patients in 2-year results showed they continued to have a sustainable visual benefit with 0.3 milligram dose and adequate safety during 2 years of therapy. However, it was discontinued because it had exclusive inhibition of VEGF-A 165 isoform. Then came the bevacizumab. Bevacizumab is a full-length recombinant humanized monoclonal antibody, and it is active against all isoforms of VEGF-A. But for ophthalmology, it is an off-label use, and it will be there. We'll have medico-legal issues if any complication like end-off comes while using this drug. But however, this drug has got a long history of safety and potency, and it is available in 100 milligram and 400 milligram vials, and it has to be allocated in small syringes, and the dose to be given is 1.25 milligram in 0.05 ml. Then there is convincing data, though it is an off-label drug, there are data, that is the CAT trial, which showed when it is compared with ranibizumab, that the visual acuity was not statistically significant difference between these two drugs, and both the monthly and PRN dosing showed a same result with both the drugs. And regarding the safety, the adverse effects like the systemic adverse effects and the serious side effects and hospitalization events were same in both the groups. So at 1 and 2 year follow-up, the CAT trial showed that bevacizumab was equally effective as its congener. Then came the EVAN trial, which also compared the same ranibizumab and bevacizumab for wet AMD and the same monthly and PRN regimes, and showed that both were equally effective, and it was comparatively cost effective when compared to ranibizumab. Then the PACOR study, which had studied mainly in central involving DME and PDR, the 5-year result showed that the visual acuity actually at 5 years there was not much of gain, but initial years there was gain, mainly because it was due to the under treatment and presence of persistent SRF. However, in PDR with previous PRP, there was marked regression of neovascularization. Then the CVOS study, which also showed that bevacizumab was equally effective at substantial gains in visual acuity at the end. And similarly, the adverse effects was common for almost all the anti-VEGF transient IOP rise, which was normalized without any intervention. And the incidence of sterile endophthalmitis and bacterial endophthalmitis was almost same in both the groups. Then ranibizumab is a recombinant humanized monoclonal antibody which binds to all isoforms of VEGF-A. And this structure of the ranibizumab is smaller, hence it is better penetration. And in 2006, it was FDA approved, and it was demonstrated by the Marina and Anchor trial. So you can look into the molecule, you can see the structure of the ranibizumab when compared to the bevacizumab. The smaller size allows better penetration because this does not have the FC domain. And the two ranibizumab molecule binds to each VEGF dimer. And it has a higher stability and greater molecular affinity. The approved dose is 0.3 milligram for diabetic retinopathy with or without DME and diabetic macular edema. And for CNVMs and macular edema due to vein occlusions, it is 0.5 mg. The half-life is 3 days, but for the bevacizumab, it was more 20 days. Then came the aflibercept. It is a 115K Dalton fusion protein. Here the IgG backbone is fused to the extracellular VEGF receptor sequence of human VEGF receptor 1 and 2. So it's basically a VEGF trap. So instead of binding to the VEGF receptor, the VEGF molecules binds to aflibercept. So the recommended dose is 2 mg in 0.05 ml and seems similar. It can be given for neovascular AMD, macular edema following RVO, DME and DR with DME and myopic CNVM. Then came the ILIA HD, that is 8 mg aflibercept, and several studies like the Pulsar and Photon trials showed similar visual gains, anatomic improvement, safety profile and durability. The main advantage of the ILIA HD was that after the initial loading dose, the need for repeat injections was less. That is 2 to 4 monthly only for wet AMD and DMB and 2 to 3 months for DR. This was because of its longer durability. Then Civ aflibercept or Zaltrap. It was a same protein as aflibercept, and similarly this was just like a bevacizumab given for colorectal cancer. It is an off-label drug and it is got high osmolarity, but it was a cheaper alternative. It is recommended dose is either 1.25 milligram or 2 milligram. There is no major ocular or systemic side effects, but there is lack of large randomized control trial for using Zaltrap. Then brolucizumab, it is a humanized monoclonal single chain fragment with higher binding affinity, and it inhibits VEGF-A, neutralizes, so it doesn't allow VEGF-A to bind its receptor 1 and 2. And the recommended doses by Hawk and Harrier studies is the 6 milligram per 0.05 ml, and it was found that brolucizumab was non-inferior to aflibercept in visual outcome, and anatomical outcomes was also favorable with brolucizumab. And some side adverse effects was the retinal vasculitis, retinal arterial occlusions, intraocular inflammation, though it is mild and self-limited. Then faricimab, the recent one, the humanized monoclonal antibody, and this has a dual mechanism, that is, it not only binds to VEGF-A but also to angiotensin 2. So it has got an extended durability. And the recommended doses by the different trials, that is Yosemite, Rhine, Stairway, Balton and Comino, is 6 milligram per 0.05 ml. And 8 to 10% there is presence of antifaricimab antibody, and there is no safety and efficacy in pregnancy, and similar to the brolucizumab, retinal vasculitis and vascular occlusions can rarely occur. Then came the biosimilars. Biosimilar is something similar to the reference drug. It has somewhat same effect, but they do not have the same identical ingredient. They are not small like biologics, they are large complex molecules. They identify the gene and then they clone into a vector, and cell cultivation is used to form a biosimilar. However, it is less lengthy and less costly process for development. And in biosimilars, it is the live cell. It is not an exact copy. You have to assess the stability, immunogenicity, and excipients are allowed. And since it is less costly, it is more cost effective and patients can utilize it. So you can see the difference that for a biologic to be approved, it is a long clinical study and everything you have to go through. But for a biosimilar, there is not much of clinical studies needed for that. So it is same with the respect to the safety and potency, it is almost same with that of the biologic. So the bevacizumab biosimilar was Mvasi, which was used as off-label for wet AMD, and it was shown that it was a viable and cost-effective therapy when compared to its original molecule. Then came the Zybe. Zybe also showed that in the macular edema due to retinal disease, the Zybe was really effective in terms of safety and potency. Then ranibizumab biosimilars we have lot, and the first which came into India which was approved was Rasumab. The recommended dose is 0.5 milligram per 0.05 ml. And these are different other ranibizumab biosimilars in the market. And in pipeline are the aflibercept biosimilars like Yesafil, Opuvis, Encivo, Asantiv, and Pavblu. So to conclude, anti-VEGF therapy has become one of the most frequent treatment modalities in ophthalmology, and the usage has become wider, and investigations are going on for new drugs which act for a long time and new modes of delivery as well. Thank you.
Thank you, Dr. Sindhu, for taking us through the various anti-VEGF molecules. And Dr. Sindhu works as a consultant in the vitreoretinal services of Little Flower Hospital.